Hi, my name is Alan Osborne. I'm the Chief Business Development Officer with Family Source Consultants. Thank you, everyone, for joining us. We're really excited about this webinar today. We have Dr. Mark Trolice, who's the director of the IVF Center and the professor of obstetrics and gynecology at the University of Central Florida College of Medicine. The IVF Center is located in Winter Park in Orlando, Florida. And I also have Staci Swiderski, the CEO and owner and founder of Family Source Consultants, joining us today. And we are going to discuss what to look for in a fertility clinic. I personally meet with a lot of intended parents, and I would say that over half of them come to us without a doctor or fertility clinic in mind. So we suggest clinics to them, and they're always asking us, well, what should I be looking for? How should I find one? What's the important thing? So we thought this would be a great topic to explore on these webinars, not just the intended parents domestically, but our international intended parents as well. If they're going to be working with a surrogate or an egg donor in the States, they're going to need a fertility clinic over here. So I thought that this would be a great thing to talk about. And Dr. Trolice is one of our favorite people to work with, and he's a wonderful personality. So we thought of him immediately. So I'm going to kind of kick it off by handing it over to Staci. Thanks for joining us.
Yeah, absolutely. Thanks so much, Alan. So as a former intended parent myself, I was faced with, where do I start? My husband and I, we built our family through surrogacy. And when we were faced with that, there was so many obstacles. It was a little overwhelming, right? When do you contact the fertility center? When do you get started with creating your embryos? You have the legal piece. You have so much to tie in together. But of course, medical always comes, to mind. So, Dr. Trolice, this is where we really want to really just utilize your expertise during this 30-minute webinar and, put ourselves in the position of an intended parent who's going to be listening and watching this webinar and what would be most helpful for them. So I think what we'll start with is kind of the timeline. So when an intended parent contacts you that is going to be facing third-party reproduction, whether it is a same-sex couple, heterosexual couple, a single intended parent, whatever it may be, and let's say they are going to be utilizing an egg donor, where would you start? What would be your first piece of advice? They're at the very beginning stages. What would you share with them with that initial consultation, with the timeline?
A great question. And first, I want to thank you both for the kind words and the invitation. I love being with you all. And your passion, Staci, really shines through. You remind us that you went through this as well. And I think that's the reason why when we have patients from Family Source Consultants, they really speak praises of you all. And it comes from you being able to express your passion for them to treat patients like you wanted to be treated when you were going through your journey. And that's sort of what I've done as well. My wife and I went through 10 years of infertility. Went through multiple treatment cycles. I mean, the roller coaster was just so burdensome. And often intended parents have gone through that too. So obviously sometimes you get the patients that come straight because of a medical complication or other circumstances that warrant immediate pursuit of using a gestational carrier. I would have to think that the patients who come to see you, the clients that come to see you, are looking for signs within you as with us, because the process is for a reproductive health clinic is about the same, right? But what separates clinics, I think, is the patient feeling that trust, the sense of accountability that you're going to have for them, saying that you really got their back. You're here for you. You're here for them. They know your credentials coming into it. Okay. Right. But what's going to separate the clinic is, are you going to be invested and an advocate for that patient? While it may be something that we are very, very comfortable doing, what I tell my staff all the time, and I'm sure you do the same thing, Staci, is that no matter, this is hundreds or thousands of times we've done this, it's probably their first. And you have to always put yourself in that position that this is their first go around. They are frightened. They are worried that you're going to tell them, "Oh, I'm sorry, we can't do it. You're not going to be able to be a parent." Certainly the cost is a significant factor as well. But what I think which is most important is the sense of trust. Do they feel confident that you're going to not treat them like a number? You're going to be able to guide them, hold their hand through the process. And I think the way, the why we have done so well together, your organization and mine, is that we partner, right? It's really not compartmentalizing the process. We work together. You have wonderful coordinators amongst your team. And, I think the patients want to know that as much as you're in Chicago, I'm in Orlando, we are really integrated in the same goal and the same philosophy of helping them along their journey. Ultimately, though, I would share that what I would recommend intended parents want to know is the clinic evidence-based. Do we practice the guidelines by the Society for Assisted Reproductive Endocrinology? Are they going to experience the latest technology and current recommendations that is going to be optimal for their care? We don't want to just get them through a cycle. We want to do everything possible to give them the success that they're looking for. And in the end, if God forbid it's not successful, the intended parents have to know we did everything that we would do again the same way to optimize the pre-treatment care and the care going through the cycle. But communication, as you do with them and as we do as well, is really key. They'll come from potentially, you've had this all over the world. Right. And it's not easy to relinquish that control thousands of miles away. So staying involved in their care, immediate communication and feedback is so important to give them the comfort and to let them know that they chose the right center for the just surrogacy agency as well as the reproductive endocrine clinic.
Absolutely, and you hit the nail on the head with communication. I feel that again, putting myself in the shoes of an intended parent myself, that communication, those intended parents, they want, and I don't blame them, they want instant answers. It's overwhelming, right? And like you said, this is something that we all do every day. So for us, we feel like, we're asked the same questions or very similar questions all the time, but for the intended parents, it's new to them. They don't want to ask silly questions, and it's very private, very personal. And sometimes they don't have that outside support either. So they're really indulging a lot of, this information with us that for them, it's uncomfortable. So I think definitely, the communication and making them feel comfortable to ask these questions is key. And knowing that the team that they've really chosen to put into place, whether that be the fertility center, the agency, the attorney, everybody really is working hand in hand to get their journey underway and as quickly and as precisely as possible. So, with that, in terms of...
Before you ask your question, Staci, I was going to say,
absolutely.
This is a rather long process. Sometimes it could take 6 months to a year. What are some of the reasons that there is a delay on your end in terms of clients coming to you? And there are obviously processes and procedures that you have for them. We, of course, have the medical contraindications of concern that we want to do everything to ensure that the gestational carrier is optimally health-wise as well as obstetrically is no concerns in that end. What are some of the reasons that there is a longer time with you?
Yeah, great. That's a great question. You're turning the page here on the table on the questions, huh? But definitely the timeline can elongate a little bit with matching them with the right carrier for them, depending on what their criteria is, what they're looking for, whether that be location of their gestational carrier or whatever it may be. Right now, our average wait time is anywhere between about 4 to 6 months on average. So that definitely, that can elongate the wait time. But other than that, then you have the legal piece. You know, once the surrogate is medically cleared, we move forward with the legal process. And so that, you know, that can tend to take 4 to 6 weeks or so. Creating their embryos, of course, you know, that takes time. When intended parents come to us and they don't have their embryos created yet, finding an egg donor if they have to find an egg donor. That's all, you know, all these little very serious, important, tedious processes along the way. And I think, again, that's where they're looking for that support and that expertise from their team, you know, that they've chosen, and that we're making time for that.
I love the fact that when we do something together, it's really a multidisciplinary team.
Yes.
We have your agency, we have the reproductive clinic, we have the reproductive attorney, and then we have the reproductive psychologist. It's just amazing how we've assembled a team to be able to do something like that. And we're fortunate enough to have a reproductive psychologist with me for many, many years. And of course, we know our attorneys that we'll use. But given those hoops that they have to jump through, it's so important to explain to the couple or an individual what the reasons for going through these type of things and how
Right.
this is really in their best interest in being able to not just ensure that they're able to expedite going through the process, but after the fact, right? You know, once baby's born, to ensure all paperwork, everything is taken care of, and we've done everything to mitigate any bad outcomes.
Absolutely. Absolutely. So important. Again, and it's just part of their team. You know, it really ensures that the process is streamlined as much as possible, that we can certainly control. So jumping back to creating embryos, this is one of the most common questions that we do receive from fertility, from intended parents when they are searching out a fertility center, is success rate. That's really important. So let's say that the intended parents are utilizing an egg donor, right? What do you share with your patients, intended parents, regarding success rates versus, and also I'm going to add on to that, if they're utilizing frozen eggs, say from an egg bank versus fresh eggs to create their embryos. Can you share about that a little bit?
Of course. I do explain the options of, you know, for many years, you and I have been in this a while, everything was fresh egg donation, right? And then in 2012, the American Society for Reproductive Medicine removed the experimental label off of freezing eggs. And that started the process for the cancer patients, but then it segued into essentially elective egg freezing for preserving fertility, and then also for egg donation. Studies have shown that they're pretty similar outcomes using fresh and frozen. I always share with the patient that they have the option of going through an agency or going through a frozen egg bank. A lot of times, if they're using a sister, a cousin, a niece, or a friend, they'll use obviously fresh egg donation. But frozen, you know, of course, is a much more streamlined process in terms of the eggs are already there. It's like a sperm bank, right? Eggs are already there. The donor's been screened. They literally can purchase a certain number of eggs, and then we have the eggs sent to our clinic. We thaw the eggs, add the sperm, and allow the embryos to develop. You know, what we try to impress upon patients is that there is a diminution from the time that you have eggs to the time that you have the embryo to transfer. It comes out to however many eggs you have, about 50% of them are going to be available to transfer because 60 to 80% of eggs are mature. Now, that's different with egg donation though, because the frozen eggs are all mature. They wouldn't be frozen if they weren't. But however many eggs you have, about 70 to 80% will fertilize, and about 50% of those go on to day 5 at the blastocyst stage for transfer. And it's important that I want to express this to your listeners. and all of your viewers in that we recommend a single embryo to transfer. These are egg donors. They have a very good success rate, the lowest percentage of chromosomally abnormal eggs, and there is really no reason to transfer more than a single embryo. You know, the Society for Assisted Reproductive Technology, or SART, has shown now that more than 90% of the live births are singletons, and probably I think 70 to 80% were single embryo transfers now that we're using in our society. That it's so important to reduce the risk of complications. You know, you've gone through so much,
Right.
and I know particularly the third-party reproduction that you're all doing. You know, they're paying a lot of money. They put a tremendous amount of investment. They want to have 2 and through. Okay, I have 2 now and I'm through. But twin, or even more, God forbid, is a high-risk pregnancy, and we can't disavow that and disregard that impact. That our obligation, first and foremost, is to have a single healthy baby, reducing the risks of complications to the carrier and baby. You know, if we transfer one, there's about a 1 to 2% chance of twins.
Right.
If we transfer 2, you still have that risk. And I've known clinics that have transferred 2 and ended up with 4. Okay, and that's not the goal. I think good. Sorry.
Sorry, I don't want to interrupt there, but
Good reproductive clinics look at twins or higher, of course, as a complication, not as a success.
right. And do you recommend, when utilizing an egg donor, that the intended parents or your patients have the embryos genetically tested?
Oh, no, I don't believe that embryo biopsy for chromosome testing of prior to pregnancy, called pre-implantation genetic testing. There is no medical evidence that there is an improvement in outcome. And we strongly discourage patients to spend that extra money for that. If they wanted gender, and if that's extremely important to them, that really is the only way to determine that, right? So we acquiesce for gender, of course, because the American Society of Reproductive Medicine does feel that family balancing, or at least selective for gender, there's no reason not to offer that, but there's also no reason to offer that. They actually wavered on that, but we do offer that to patients if they want that. But if it's for the patient that says, I want everything, I wanted to test everything to make sure everything is perfect, that's not going to do it. There's no medical evidence to support that. And so I say, look, I would save the money. You're going to have, in women less than 35, clearly, there's no higher success rate in doing chromosome testing by PGT, that pre-implantation genetic testing, than those who don't.
Now, what if the intended parents really want to have twins? Let's just say, hypothetically, it's a same-sex couple. They would like to have twins, transfer 2 embryos. Are you open to it if they really would like that?
That's a very difficult question. And what I tell them that is that I wish you gave me a different answer as to why. You know, when I say, why would you want 2 embryos transferred? Oh, because we want twins. And that puts me, and I think all academic reproductive endocrinologists, in a very difficult position, because what you're saying is that, hey, doctor, can you increase my risks for this pregnancy? And I know that's not what they're asking.
Right.
But that's, in medical terms, that's what you're doing. You're increasing the risks to baby as well as to the carrier. The carrier with a multiple gestation is having higher risks, potentially high blood pressure and diabetes, preterm labor and delivery, even mortality, although it's slight, is a higher risk. Babies, prematurity, low birth weight, miscarriage, birth defects, respiratory neurologic problems from prematurity, it's not the way to go. Everybody sees the happy twins and nobody sees the tragedies that can occur, although the doctors do, of course.
Of course.
I really discourage that and ask them to pray about this, that this is not the goal. The goal is a single healthy baby.
Is one healthy, chubby little baby, full term, correct, absolutely. So let's talk about the criteria for a gestational carrier. In regards to, and it really is case by case with different fertility centers. Do you require the surrogates, the carriers, to be vaccinated for the COVID vaccination? Is that a requirement?
I have been an advocate of the COVID vaccine from the second it was on the market. What I recommend for all of my patients is to optimize the health before you carry a pregnancy, whether it's diabetes, thyroid disorders, hypertension, so on and so forth. In the original times of COVID, we strongly recommended vaccination. We still do. We don't refuse a patient who is not vaccinated, but I share with the intended parent that we strongly recommend vaccination prior, particularly for how much the intended parents are going through for this situation. And there really is no medical reason other than the rarity of an allergy that would preclude COVID vaccination. I have talked to infectious disease specialists. Is there any medical reason that somebody cannot take the vaccine? And they say no, they don't know of any. So I understand the independent personal choice in their own body, but now you're carrying for somebody else. And every and anything that you do should be with that intention. And I think it's really the responsibility of the gestational carrier to optimize every aspect of their health, including COVID vaccination, prior to taking on this magnanimous, selfless gesture. I think it should just go through every aspect of it, including the COVID vaccine and the flu vaccine. I mean, anything that you can do to reduce harm to yourself and baby.
Maximize, the protection. Yeah, absolutely. Thank you for that. Alan, did you have any questions?
Kind of maybe jumping back towards the beginning. I'm talking to intended parents that need an egg donor, or they don't have a clinic and they just don't know when they need to find that clinic. Like, do they need to decide their clinic based off of where their egg donor lives? Or do they want to get matched with a surrogate first and then get their clinic? When should they clinic first, figure those things out later, or vice versa?
Well, it's really time constraints that enter into the decision. If it is an autologous, where the woman is using her own eggs as the intended parent, right? And if she is of advanced reproductive age, then you may want to, at that point, remove the eggs through the retrieval procedure, add sperm, and then freeze the embryos. Because it's usually a lot faster to find the egg donor than it is the gestational carrier, because that relationship with the gestational carrier, as you all know, is very, very strong. And the comfort level of the intended parent has to grow in that relationship of trust and openness. So I say, if there's any timetable constraints, then let's just get these embryos frozen and then we go from there. If they're using a fresh egg donor and the fresh egg donor is in college or has a work schedule that precludes them from doing something in 6 months or so, they may want to do that now. But those are individual circumstances. But in an ideal world, sure, get a gestational carrier, lock that in, because you can certainly get an egg donor and or sperm donor, or use your partner in a more expedited manner. So I think it really is the individual circumstance. What do you think, Staci?
I think that's great feedback. Definitely from a gestational carrier's point of view, I feel that they highly like it when the intended parents already have embryos created. It just really speeds up the process a little bit for them. And there's no real bumps, along the way, in either finding the intended parents finding their egg donor or creating their embryos, however that may be. But the surrogates, I think they really like the fact when the intended parents have the embryos created, ready to go. And sure.
Avoid the time delays, because life gets in the way and events happen.
Absolutely. Yes. Yeah, absolutely.
Yeah,
And
leaving that window there for anything to happen is probably not the best idea, right?
yeah, absolutely. And we also share with our intended parents as well when, they don't have a fertility center yet and they're really just coming to us, just scratch, brand new, starting the process that, we certainly encourage them when they do decide which agency to work with, go ahead and sign up with that agency because there is going to be that wait to match with their surrogate for the most part. Like I said, ours is about 4 to 6 months. And during that time, while they're waiting to be matched with their surrogate, they can certainly then decide which fertility center they want to work with and then move forward in creating their embryos.
I wanted to touch upon reasons of not proceeding. So from a medical standpoint, it's our responsibility to ensure that everything is optimal from a medical standpoint and psychosocial standpoint, right? By using our psychologists. So any red flags that come out of that session, we definitely want to address. And if they can't be cured in terms of taking care of the concerns, then we really express to the intended parent, we don't think this is a good idea to move ahead. What parts of the, what aspects of the gestational carrier medically would we not want to proceed? Well, any uncontrolled medical problem, of course, like diabetes or hypertension, if they had pregnancy complications, okay, multiple miscarriage, significant hemorrhage at the time of delivery, cervical incontinence where the cervix is so weak that they have to put a stitch in the cervix to try to save the pregnancy. If they have had infertility before, and if when I talk about medical conditions, I also respectfully want to say body mass index. We'd like to keep that in a range that is not putting the pregnancy or the carrier at risk. The body mass index issue, I mean, the whole country is sort of going a little bit more toward an elevated body mass index, which is not really good news for physicians who want to try to care for these patients, and certainly obstetricians. But a body mass index, we'd like to keep it below 35 to 40. We share with the intended parent that, it would be great if it was less. Above 40, you're dealing with a further increase in that aspect. What about age? Well, the same type of thing. We'd like it to be below 35 to 40. I don't like the term geriatric pregnancy. Have you guys heard that term? My gosh.
We have, yes.
I never knew what that meant, geriatric. So anyway, but well above 40, you're also getting into risks of concern as well. So when you see clients that come to see you, do you have situations that you would say, this circumstance is really not looking ideal for us? Because I know you're so much into customer service, but with tremendous integrity. Are there circumstances that you would say, I don't think it's a good idea that we move ahead, or at least not at this point?
We certainly do with surrogates on gestational carriers all the time. We probably accept maybe it's definitely 5 to 10% of the actual, the surrogates who apply with us, and for a number of reasons. It could be, their BMI is just too elevated, their age, sometimes it's location, obviously their previous pregnancy history. We do have 2 nurses on staff that review those records. So from an agency perspective, we certainly do our due diligence in terms of matching. So that way, once we have completed a match and the intended parents and the surrogates have agreed to move forward, we want to make sure that the surrogates records, the psychological evaluation, everything has been completed on our end before we even share that with your team. We certainly don't want to waste anybody's time, the surrogates, the intended parents, yours, ours. So again, we really do our due diligence in screening those surrogates as much as we can, and then certainly accepting the surrogates who apply.
What about the intended parents? I neglected to say that we do have an age cutoff. We really struggled with this.
It's hard, yeah.
So what we did is that we really felt that the combined age of more than 100 for the intended parents is really our ceiling. No one of the parents, you know, for someone that's going to carry, in other words, if we had our patient carrying, we don't do above 55, but we do the combined age issue. And that's sort of, I've seen that at other places as well. Do you have any issues there or any other reasons for intended parents to be a
Yeah, the age factor, we really leave that up to the fertility center. But we've seen that where it's typically 100, 110 for a combined age. But again, we really leave that up to you as the fertility center. Ellen, do you have any?
I was going to say the age that we would leave that up to the fertility center. And if we were to move forward with them, and if 100 is around the age, the combined age, you know, we would want to have a mental health evaluation take place and make sure that there's a support system in place, you know, for their unborn child in case something happened to where, you know, they weren't around.
Yeah, definitely the intended parents have to all have the mental health in place prior to proceeding. Yes.
Yeah, that was
regardless of age.
Is that we would want to, you know, we make our intended parents go through a mental health evaluation to make sure that they're, you know, mentally healthy to move forward with this journey. So it's a big part of the entire process because it's such an emotional, and adding to the financial part of it and the time and what they most likely have been through to get to this point. It's just a lot. So we want to make sure that they're okay and ready to move forward and ready to take this on.
I try to tell the intended parents that the meeting with a mental health counselor or reproductive psychologist is not to determine if they're crazy. Okay, it's really an education process.
Yes.
That lets them try to experience what it's going to be like. And if it's a donation process, when to tell the child, how to tell the child. I'm a tremendous advocate of full disclosure as soon as possible. And so it's really, you just don't want to go to someone who is a counselor or a licensed mental health counselor. You really need to have somebody who is well studied in the area of reproduction and third-party reproduction. Just like when we use our attorneys, Stacy, you want to have somebody who is very, very knowledgeable on third-party reproduction and parenting, but also the particular state in which the intended parent is going to be using the gestational carrier.
Yeah, definitely. You know, third-party reproduction, there's so many areas that really you want to work with the experts that are really, really knowledgeable within that field. It's so important. And with the psychological piece on the surrogate end or the donor end or the intended parent end, you know, those experts are really going to touch on some really important topics during that evaluation. That is just, it's critical in the outcome. And not only in preparation for it, but after the fact, it's so important, you know.
Do you know if the intended parents and the gestational carriers typically stay in touch for a long time, or is it really just the first year or so?
It's typically, it's for quite a while, sometimes forever, you know, as long as we've been helping to build families now for almost 16 years, we have many journeys where the intended parents and the surrogates are still in contact. You know, sometimes it's not as much as it was prior, but definitely throughout the year, you know, there's always those milestones, birthdays, holidays, special events where they stay in communication. And that's really important during the matching process too, that the intended parents and the surrogates really fully disclose what they are interested in, what type of relationship. And that really comes into play during the matching process where we're sharing profiles that has to be aligned. It's so important for the overall journey.
It's always interesting and fun when we do the obstetrical ultrasound at about 7 to 8 weeks, and it's a third-party reproductive scenario. We have the gestational carrier's partner, possibly friend. We have the intended parents in the room. I'm in there. My medical assistant is there. I mean, it's standing room only. And we've had some exclamations of joy that have been quite loud inside of a room. But it's uplifting. I mean, it's
quite exciting.
Isn't it the reason that we're all doing this?
Absolutely, absolutely. Those joyous moments it's what it's all about, really, it really is. So, I feel we could ask you questions for days and days and days. So we definitely have to reunite and do more of these, because I feel we could extend on this, over and over. But we'll end it for today. I know we've gone over a little bit. So thank you again, Dr. Trolice, for your time. And staying on a little bit longer. We really appreciate that. But if anybody has questions who within the audience, feel free to reach out to Dr. Trolice directly. Of course, us, Dr. Trolice, can you share what's the best way to contact your office?
It's very easy. We are the IVF Center. So info at theivfcenter.com.
Perfect. And we'll definitely have your information and the link too. But again, thank you so much for your time. It's been so much fun, and we'll see you next time.
Yes.
Always a pleasure to be with you both. I thank you for the opportunity and the honor to sit down with you. We share our patients, and I'm very privileged about that as well. So great to see you all. I hope this was valuable for your viewers, and I'm always available for any future events.
Yep.
Thank you so much. And likewise, thank you so much, and have a great weekend.
Yes. Thanks so much.
All right. Bye, everybody.